fluid-air exchange is an essential step during retinal detachment repair. Relieving complete vitreoretinal traction before fluid-air exchange is mandatory, as persistence of peripheral anterior traction may lead to complications such as subretinal air migration. The following video demonstrates subretinal air migration during fluid-air exchange in a case of an aphakic inferior bullous retinal detachment and its management. After 360 degrees encirclage and creation of standard 20-gauge vitrectomy ports, anterior vitrectomy and core vitrectomy are performed. The fundus shows an attached superior and superonasal retina, an inferior bullous retinal detachment involving the macula with breaks and lattices inferiorly. A complete vitrectomy is done and vitreous along the lattice is trimmed. After marking the breaks, fluid-air exchange is started. Posterior subretinal fluid is completely removed and the retina is attached posteriorly. However, towards the completion of fluid-air exchange, there is subretinal migration of air. The surgeon tries to suction out the trapped air through the breaks using a flute needle. Because of elevated retinal break, air cannot be left subretinally. During the attempt to remove subretinal air bubble, further air migration is noted. Infusion is restarted to repeat fluid-air exchange. However, the same complication is encountered. PFCl or perfluorocarbon liquid is injected, which is also found to migrate subretinally. However, this PFCl is removed. In suspicion of a peripheral traction as a cause of subretinal air migration, 3 to 4 clock hours of inferior relaxing retinectomy is performed, but unavailing. More PFCl is injected and a 360-degree relaxing retinectomy is done. While performing relaxing retinectomy, subretinal bands are encountered, which were the probable cause of unrelieved traction that encouraged the entry of subretinal air. Relaxing retinectomy is done in the attached supranasal quadrant also, lest it be the cause of subretinal air migration. 360 degrees of endolaser is performed at the edge of the retinectomy. Silicone oil is exchanged for PFCl, and encircling band is removed at the end of the surgery. Thus, this case suggests that subretinal air is usually a preventable complication directly related to unrelieved vitreoretinal traction as a cause of subretinal air migration, requiring a combination of procedures like scleral buccal, thorough vitrectomy, removal of all subretinal bands, and relaxing retinectomy.